So, just to take a step back, I think about 50% of patients with melanoma will have BRAF mutant disease and 50% are BRAF negative disease. I think, if you look back at the performance of different types of tests, what's interesting is that a lot of tests are very sensitive for V600E mutations, but not so much for V600K and D and some of the less frequent V600 mutations. So at our center, it's commonplace for patients who are negative on a V600E test. And actually in our center, we use immunohistochemistry test, which again, is more sensitive for V600E, but not for the other lesser frequent V600 type mutations in BRAF. And so for the patients who are BRAF negative by the first screening test that's used, it's commonplace and common practice at our center to retest them using a more high fidelity test, either using next generation sequencing, that's what we do, or you could use the test, the bioMérieux test, or some of the other tests that employ Sanger sequencing. I think what's interesting in the whole BRAF testing field is that the FDA approved test actually is not, which I think is a COBAS test, is actually not specific for V600E mutations. It'll just pick up a lot of any changes in the V600 position. So it can pick up some other V600 mutations, but not necessarily pick up all of the V600Es. And some of the other tests have their own peculiarities. So it's a good idea to test people who are negative with the first generation or the first screening test, because a lot of those they're more specific than they're sensitive.